Good morning everybody, I hope you've slept well, and I'm going to carry on really from where I left off last night to a certain extent. I would prefer this to be a conversation rather than a lecture. So I'm going to use my slides to talk to you about different aspects of where we're up to with the treatment of OI. But I would like you to interrupt me and ask me questions as I go along. That means that if I don't finish, you still had a chance to ask questions. Trish has just told me I've got an extra 5 minutes, which is always a bad thing to give a speaker, because they'll ramble on. But if you've got a question, stick your hand up as we go along, and I'll do my best to answer. Okay. For the last 15 to 20 years, we've been using intravenous, that's what IV means, bisphosphonates. These are drugs that prevent your bone cells destroying bone. The ones that we've used most often are permethrinate, intravenously, and more recently, the most potent of all of the bisphosphonates is called zoledronic acid. Other drugs that are available for use intravenously are called ibandronate and neridronate. They all end in dronate, you may have noticed, or dronic, for zoledronic acid. We know a lot about permethrinate because it's been around for so long, but we are still learning more about it as time goes by. We think that it sticks very strongly to bone, and it probably stays in your skeleton for decades after you finish taking it. There was some work that was done quite a long time ago by a Dutch group that showed that children who'd stopped taking this permethrinate 10 years before were still excreting it in their urine. So we've known this for some time. And we don't know whether that's a good thing or not. We assume that if it's there, it can still be active in terms of slowing down the rate at which you destroy bone. And that's not necessarily a bad thing when you've got OI, because your normal rate of bone destruction is 2 or 3 times higher than normal. So, are there any differences between these drugs? Well, the main differences are, with zoledronic acid, you can get it given to you over a 30-minute period, whereas permethrinate typically takes 2 or sometimes 3 days. So from the convenience point of view, zoledronic acid wins hands down. But we don't know what the long-term effects of zoledronic acid are when it's administered over a period of many years. And we won't know for some time because it hasn't been used for as long as permethrinate has been. These drugs, given intravenously, are more often used on the continent, ibandronate and neridronate. I think they're all pretty much the same level of effectiveness as we use them in OI in terms of reducing fracture rates. But as I say, we have the most information about permethrinate, and in this country, the least information about these two. Any questions? Yes? Fire away.
Are there any immediate symptoms from, sorry, not symptoms, side effects from zoledronic acid? Because first I mentioned permethrinate, I felt really ill.
Yeah.
But I don't know about zoledronic acid.
They all do that, basically. Even the ones that are given by mouth will provoke that kind of reaction, although when you take medicines by mouth, it tends to be over a longer period of time. You get feeling a grumbling, sort of flu-like symptoms for a couple of weeks sometimes. You can damp those feelings down by taking something like ibuprofen the first time that you have the medicine. It's typically only the first time that you're exposed to any of these drugs. And when you've had one of them, you don't tend to have that same reaction if you move to a different one. But the reaction that you describe is very typical, and it's seen in about 75–80% of patients who take these medicines the first time they have it, whether they got OI or not. Okay.
Have you found that there's any substantive difference between taking these drugs orally as opposed to intravenously?
I'm about to come on to that. Okay. So, oh, sorry, there's another one.
just quickly really, midranate you obviously have to take like every 3 or 4 months. There's one now, isn't there, that you only have to take once a year?
Yeah, that's the zoledronic acid. So if you're an adult with postmenopausal osteoporosis and you're in your, say, your 75 plus, often once a year dose of zoledronic acid will keep your osteoporosis under control.
Right.
For children, which is who I deal with, typically you give the zoledronic acid initially every 6 months, but once their bone densities come up into the normal range, you drop that back to once a year. And that's what they're doing in Montreal at the current time. We, in Sheffield, haven't used zoledronic acid so much as yet. We are going to start using more of it, I think, as time goes by. So we don't have the same level of experience here. Birmingham have used zoledronic acid quite a bit.
What about, you talk about children and then osteoporosis in older people. What about using the bisphosphonates in young adults with OI who perhaps had bisphosphonate when they were younger and then stopped for several years? Is there any merit in starting up something again?
That's a really difficult question to answer, and I think it would be something that you'd need to look at on an individual basis with your own doctor. Okay. And that's what we do when we're considering whether we start these treatments at all in anybody. You always look at the individual and decide, is it in their best interest to have something like this?
Okay. Okay, thank you.
Okay, so oral bisphosphonates. So these are medicines you take by mouth instead of having through a drip. They've got a good safety record in OI. We've published last year in the Lancet a big study involving many children in many countries, 20 countries altogether, 147 children aged between 4 and 16. And for the first year of that study, the children either received a blank pill with no activity, a placebo, or they received risedronate. All the children also received calcium and vitamin D. There was no difference whatsoever in the frequency of any side effect between the two groups during that placebo-controlled phase of the study. So for children taking these medicines, we can say that we think they're not only safe, but also the results of that study show effective because we reduce fracture risk in those who had the treatment by 50%. But, and there's always a but, one strange thing came out of that study, and that was that there were apparently more changes in the spine in the children who had the active treatment at 1 year compared to baseline. And the reason for that's not clear. It could be that because they felt a lot better on the treatment, they went a bit mad, as children tend to, and rushed around, bounced up and down, and did some damage to themselves. That's one possibility. Another possibility is that because they've been treated, at the end of that first year, it was much easier to see the outline of the building blocks in their spine than it was in those who hadn't been treated, and so any differences were easier to detect by the X-ray doctors who were looking at the films. We don't know what the correct answer is, but what we are saying to people is we're giving them advice. If you go onto a bisphosphonate, initially, don't go mad. You know, just because you feel a huge amount better, don't think that you can go around behaving like a lunatic and jumping off things, going on bouncy castles, going on trampolines, all that kind of stuff, which is, of course, if you're 6 or 7 years old, what you really want to do. Don't do that. Just take it easy, be sensible, and sort it out. Over the course of the whole study, there was no difference between the two groups in the number of severe changes in the spine. So that's where we are with oral bisphosphonates. In general, if you've got more severe OI, my perception is that you do better, at least initially, with the intravenous bisphosphonates than with the oral ones. And we did another study a few years back where we looked at different doses of an oral bisphosphonate. You need bigger doses if you've got more severe OI to increase your bone density, as measured by a DEXA machine. So in mild OI, which is the big study that we just talked about, there is a decrease in fracture rate of about 50%. But these were kids who generally we would not normally have jumps in with treatment at that stage. As I say, there's an uncertain effect on what happens to your vertebrae. Yes?
You were saying if it was more severe OI, then maybe the recommendation is a bit more to go with the oral side. If it was mild, is your recommendation or advice to go more with the oral rather than IV?
I think it's horses for courses. So if you've got somebody who's got very slight changes when you look at their spine X-ray, you would offer them the choice. You'd say you could take oral therapy and see if that sorts things out. There's always the option to change from oral therapy onto IV, and vice versa. If you've got somebody comes along and presents with, as a child, multiple vertebral crush fractures, what we know is that with continuing bisphosphonate treatment, you see the vertebrae get bigger and go back to a more normal size and shape. And that happens more quickly if you get the IV treatment. Okay, it'll happen over a period of, say, 2 to 3 years, whereas with oral treatment it can take 5 or 6. Okay. There's some interesting questions that come out of the data that we've got. One of the things that we found from the placebo-controlled trial was that the difference between the two groups in fractures became apparent after only 6 weeks. Very quick difference. So we know that in that period of time, it hasn't changed your bone density. So what has changed? The answer is we don't know. And it's a really important question for us to try and work out. Should you treat people if they're not fracturing to try and prevent fractures in the future? Difficult question. We don't at the moment in Sheffield, we tend to. So what has changed? The answer is we don't know. And it's a really important question for us to try and work out. Should you treat people if they're not fracturing to try and prevent fractures in the future? Difficult question. We don't at the moment in Sheffield, we tend to wait and watch. Because part of the problem is that once you start giving somebody a bisphosphonate, it's quite difficult to stop it when they've been on for a while. The reason being that you create bone by treatment which is stronger and stiffer than the bone that you had before. So if you then stop treating, you end up with these blocks of bone in the middle of long bones that are stronger and stiffer. It's like having a rod in the bone that's too short. And if you look at what happens at the end of a rod that's too short, the orthopaedic surgeons will tell you this is what you call a stress riser. And this is where you tend to break if you fall over. We are now giving advice to people about moderating their activity once they start on treatment and feel better. Please don't go mad. Should everybody who takes a bisphosphonate also receive calcium and vitamin D? This is normal practice in adult osteoporosis. Children hate taking calcium. They dislike the chalky taste. There used to be one that was chocolate flavoured and which was great, and it got taken off the market some years ago. So we really struggle getting kids to take calcium. We ask them to increase their dairy product intake, more yoghurt, more milk, and so on. But we're not sure, given that that's the advice that we've been given, that that's enough, because that was the advice that we gave in our study. Maybe they should all take extra calcium and vitamin D. We don't do that at the moment, maybe we should. I think the final question is one that will interest a lot of folk here. The bisphosphonates seem to be ineffective in adults compared to the apparent obvious effects that they have in children. And again, we don't understand why that should be. Any questions? Yes.
Thank you. I'm 53 years old, and a few months ago I was put on a Creed D3 and alendronic acid, both of which made me extremely ill, my bones went rigid. I was very ill, and I had heart palpitations and everything like that. So I was promptly taken off these drugs. And I'm just wondering, I am so petrified now of any of these sort of drugs. What can I take? Because I need something. And the consultant whom I am under is treating me as if I have osteoporosis, when in fact I have osteogenesis imperfecta since birth, not since the menopause. And it's such a worrying thing for me that I am now reaching midlife crisis, as it were, and nobody knows how to treat me in my part of the woods. And it's a worry for me that I would rather have the pain of a broken bone than having the pain of a drug that's made up of chemicals. Does that sound
No, I understand.
wrong?
I think what you're highlighting is the problem that we touched on last night, where we don't have any medicines that are specifically designed for osteogenesis imperfecta. All of these medicines are designed for osteoporosis, and they are sold primarily to doctors who prescribe, to systems or commissioners, healthcare systems that prescribe for osteoporosis, because that's a huge problem as you get older. And so that's what we have currently. So these are the medicines that we do have. There are differences between the individual members of the family of bisphosphonates. So I think rather than trying to treat you from the podium, as it were, my advice would be that you need to find a doctor who understands osteogenesis imperfecta and talk through the options with them. But the problem is for us at the moment, these are our options. That's it. That's what we've got.
Does there come a point, depending on age, where you can change the drug that you're on? Because I was on Originate from about the age of 10 to 15, and then went to Originate, which I'm still on now, and turned 18 in a couple of weeks. So I haven't broken touch with it. I'm very grateful for this in nearly 4 years. And when I turn 18 and onwards, does there come a point where I need to change the drug because of anything to do with my age, or is it just dependent on how the bones are doing?
Yeah. So what we aim for, what all doctors aim for when they're treating people with this condition, and with any other condition, is individual therapy. We don't try and treat you as if you're just a member of a herd of things like this. So we have these options, but we try and individualise it to you. So for somebody who was in your situation was coming along to us, you'd be looked after by one of my colleagues at the adult hospital who deals with young adults with OI, and she would go through with you the options that you have, which would be to continue on your current medication, to stop it for a while and see how you feel, with the option of going back on it again later if you didn't feel very well. Because what we found is that once you stop taking bisphosphonates, some people are fine. They're absolutely fine. And they come off and they say, I don't need it. My energy levels are good. I don't feel any pain. But other people, after about 3 or 4 months, say, I really don't feel very well. And I'd like to go back on and see how I feel then. So it is very much an individual thing. But there's no specific age. And it's a question of working with your doctor to find out what suits you. Okay.
You mentioned the age that they become less effective than adults. For someone who's been on bisphosphonates from birth, really, and they're coming into adulthood, do you find that the treatment becomes less effective and maybe prone to more fractures later? Or does that the effects that it's having then from birth follow through with them right in the adulthood?
It's a really good question, and I don't think we have very detailed data on that specific question. It's one that, because the cohort of children who've been treated from a very early age is just hitting the age that you're talking about now, that's the information we're trying to collect. But it's worth remembering that if you look at fractures in children who are apparently healthy, fracture rate gradually rises in both boys and girls from the age of 2 onwards. Boys always fracture more than girls do, because boys are stupid. And weak. That's what my wife says anyway. Until you get to the girls about the ages of 11 to 13. And then fracture rate starts to fall. And for boys, it keeps going up until you hit between 13 and 15, and then it starts to fall again. Doesn't mean the boys stop being stupid at that point, but what's happening is that their growth is slowing down. So there's a big peak of fractures around the time when we're growing more rapidly. And we know that in otherwise healthy bones, there are changes going on there that weaken the bone at that particular moment in time. And then they improve again after that. So that's why there's a big peak at that particular time. So the answer is, it's probably going to get worse before it gets better.
Yes, my remark would be that I think the response is also highly individual. So in my case, I was on yet another oral bisphosphonate, and as an adult, I had a very good result with it. So it is possible to have a good result as an adult. I now stopped taking it for about 1.5 years, and now I'm worried, or I'm thinking, well, each time that I have a bad week and I feel in pain and tired, I think, is it because I'm no longer taking the bisphosphonates, or am I just having a bad week?
I think that's a really useful insight, thank you. I mean, the trouble for me is, of course, as a paediatrician, I don't see what happens after we hand the guys over. We are working closely with our colleagues at the adult hospital, but having this kind of conversation, this feedback, is really helpful for us trying to work out how things are going to be in the long term. So thank you for that. Oh, one more.
My daughter was on pharmacological from about the age of 6 or 7. And by the time she was around 11, everyone was thrilled with the way things had gone, and she'd had surgery to replace the rods at GOS, and her consultant there said, "Oh, amazing, really hard bone, really pleased." And within less than a year, she was just standing one day walking, and she fractured both femurs with no trauma whatsoever. And when I questioned him over why this had happened, when he'd been so thrilled with the results of the drug therapy, he said that that wasn't the full story, but he would never explain what he meant by that. Over to you.
Oh, keep that. So, okay, a bit of detective story. I think probably what he meant was that whilst the treatment is effective in increasing the amount of bone that you have, and as a surgeon, when you go in to do surgery on a bone that is untreated, I remember the surgeons used to describe the bone as being like soggy cardboard. And that wasn't because the treatment has changed the material property of the bone. It hasn't altered that. It's still the same stuff. There's just an awful lot more of it. And in actual fact, if you take a piece of bone out of somebody who's never had a bisphosphonate that has OI, and you actually measure its true density using sophisticated techniques, bone in OI is dense. Okay? It is more heavily mineralized than normal bone, which is why it is brittle. The trouble is that when you're not treated, you haven't got very much of it. And it's in such a spongy, honeycomb-like state, even in the tube walls of the long bones, that it feels soft and deforms and breaks easily. When you get the treatment, you fill in a lot of the holes. You thicken up the cortex, the tube wall of the bone, and the bone feels a lot harder, but it's still brittle. Okay, it doesn't change that aspect of the material that the bone is made of. And that's one of the problems, that the treatments we have don't affect how the bone material behaves. Okay, so it remains brittle. Okay. long-term follow-up. So this might answer some other questions in a slightly different way. When you treat a growing skeleton with bisphosphonates, you see a rapid increase in bone density measured by DEXA. The DEXA machines, the bone density machines, don't really measure bone density. They measure how much bone you have got. So as you put more bone into your skeleton, you'll get a higher value. So there's an initial increase because you start off with too little bone, and then it gets up to a sort of a plateau. It follows the normal growth curve, and it may be within the curve, or it may be slightly below and parallel to it. If you stop giving bisphosphonates before growth has ceased, as I said, you end up with stiff bits of bone in the middle of your long bones, and that can create these things called stress rises. There was some work published from Sheffield, which was from my surgical colleagues, I didn't have any direct involvement with it, where they looked at the position of femoral fractures going back over 15 years to when bisphosphonates first started being used, and they found that the position of fractures has gradually moved up towards the top of the bone. And that may reflect the fact that the bone is becoming stiffer generally. But there are no cases of this horrible disease that's been reported in some adults taking bisphosphonates called osteonecrosis of the jaw in anyone with OI at all, whether they're children or adults. So for that, much thanks and much relief. This was something that came as a bit of a shock to me. This was data that was presented in Chicago back in April. When they looked at the registry that they're collecting in Baltimore, 44% of all of their cases of OI on the registry had had some spine surgery. So I hadn't been aware of that, and that's why I was just flagging it up. But I think that includes operations for building blocks that are slipping slightly at the base of your spine, as well as spines that are slightly curved. Okay. Yeah?
I also have brittle teeth, which I know isn't common in everybody, but it is in some people. Does the bisphosphonates help with teeth as well?
I don't think so, as far as we can tell. What we do know, though, is that good dental care, particularly of your primary teeth, is really important. It will help protect the secondary teeth. The other thing is that if you're on bisphosphonates from an early age, the eruption of the secondary teeth can be delayed, usually by about 12 to 18 months. Okay. Yes?
Hi, I've been told that I know other people have as well. When you go in for dental work, they say to you, are you on bisphosphonates? And if you say you are, they're very against giving you operational treatment. If you're saying there's no cases of osteonecrosis of the jaw, why is that?
Because they're frightened.
What's the basis of their fear?
The basis of the fear is that in other adults who don't have OI, operations are associated with an increased risk of ONJ if you are on bisphosphonates. The risk seems to be highest with zoledronic acid, the most potent of bisphosphonates, but that is the drug that is given most frequently to people who've got bone disease as a result of cancer. And some of them have had cancer that's spread to their bones, and they're taking zoledronic acid because their bone pain is so severe, it is the only thing that will keep it under control. But if you've been treated for cancer, you've had lots of other horrible drugs. And some people who've had cancer as well have been smokers in the past, and we know that there's an increased risk of ONJ with smoking. And there's also an increase, probably the biggest increased risk is poor dental hygiene. So that's again why it's really important to keep your teeth nice and sparkly white, basically. Okay. Now, PTH. I mentioned PTH briefly last slide. This is not an area of my expertise. We're not allowed to use PTH in children. It has a little black box next to it in the national formulary, and the reason for that is that when they fed PTH to a particular type of rat, it developed bone tumours. So we're not allowed to use it in children because obviously children are just like certain sorts of brat. Unlike adults. So a paper which was published in one of the important medical journals, the Journal of Clinical Investigation, in February of this year, looked at spine bone density in patients with OI, a quarter of whom had quite severe OI. They also looked at this thing called vertebral FEA, finite element analysis, and they used a technique called volumetric QCT. So you've all heard of CT scanners for doing brain scans and things like that. You can use them for looking at your bones anywhere in your body, but you can particularly look at the back. And it gives a three-dimensional image, whereas DEXA only gives you 2D pictures. Because you can get 3D, they can actually look at honeycomb structure inside the building blocks, and they can do reconstruction of those, and the engineers can create computer models of them, as you would do for an engineering structure, and then they can subject that to testing in the computer, if you like. So that's what finite element analysis is. What they found was that if you've got mild OI, then you did see an increase in bone density, and there were changes within the individual vertebrae as well, with a 20% increase in the amount of honeycomb bone that was in the vertebrae. Now, compare that to bisphosphonates. Bisphosphonates do not, at least in children, increase the number of the honeycomb bits of the bone that are inside your vertebrae. It did increase the vertebral strength by about 15%, but it was less effective in type 3 and type 4 disease. So, is it worthwhile? Well, it seems to be good in mildly affected individuals, but less so in those who are more moderately or severely affected. A bit like bisphosphonates, to be honest. So whether it is an advantage or not, we don't know. You can't take PTH for a very long period of time. This study was done over a period, if I remember correctly, of about 6 months. And the license for the drug means that you only use it for a period of months. And then when you stop taking it, you go back onto a bisphosphonate afterwards. Denosumab is a new treatment that's being licensed for postmenopausal osteoporosis again. It's another drug that stops you destroying bone. It's given by injection about once every 6 months, and it's like a light switch. You literally switch off your ability to destroy bone for that period of time. Once you stop taking it, though, there is a rebound effect, and your bone destruction will accelerate. The advantage to it is it doesn't stick to your bone. It doesn't accumulate in your bone. Once you stop giving it, it's gone. So it may be something that we do look at more so in the future, and particularly for children and for girls, where if you accumulate large amounts of bisphosphonate into your skeleton, one of the concerns has been, what would happen if in your 20s you become pregnant? Will you release that bisphosphonate? Will it cross the placenta? So far, the answer seems to be no, but we don't know for sure whether that's true for all of the bisphosphonates. The interesting thing about denosumab, beyond what we see with bisphosphonates in adults, and this is all adult data about osteoporosis that was presented at the meeting I went to in Chicago, is that unlike bisphosphonates, where after a period of time you have increasing bone densities and levels off, with denosumab it keeps going up. Whether that's a good thing or not, we don't know. A drug that most of you will not have heard of is odalacatin, and this is a drug that is still going through research trials at the moment. It does not have a license. And again, the trials are directed at postmenopausal osteoporosis. It goes by the name of a cathepsin K inhibitor. Basically, it stops you destroying bone again. It increases the amount of bone that you put on the outside of bone, like bisphosphonates, and it increases the thickness of the tube wall of bones. This is in adults, not in the growing skeleton. So this is quite interesting from that point of view, because bisphosphonates don't do this in adults. And there is a dose-dependent suppression of bone formation, which is less than what is seen with bisphosphonates. So my perception is that this, out of all of the current treatment options for adults, although it's not a treatment option at the moment, this is the one which I would go after if I was doing a study in adults with OI. Now there are some suggestions about what studies in OI adults should be, but this to me is one that I would be more keen to investigate than any of the other ones that are currently being suggested. Having said all of that, there are some other new drugs out there on the horizon. These drugs, FK506 binding proteins, and inhibitors, are nasty drugs. They are used in the treatment of people who've had transplants as immunosuppressive agents. But if they were altered in their structure slightly, they could act as things that would increase bone formation. This drug, the anti-sclerostin antibody, made by a company called Novartis, has actually been through a clinical trial in young adults in Montreal, but we don't have any results from that study as yet. Excitingly, is this one, anti-TGF-beta antibody. TGF-beta is a chemical that we all make in our body, and we embed it in our bones. And we embed it associated with another thing that keeps it quiet. We think that when you've got problems like OI that disrupt the bone matrix, that TGF-beta gets released abnormally from the bone and acts locally to cause irritation to bone tissue. It may also accelerate the death of bone-forming cells, or at least their progression through to a mature form which doesn't make much bone. It's being used in studies of adults who've got particular kidney disease, where it seems to be both safe and possibly effective. Most interestingly, it was used in a mouse model of severe osteogenesis imperfecta. If you've got a loss of CR-TAP, this protein gives you OI type 7, okay, which maybe you have or haven't heard of. We know of one child in the United Kingdom who's got a double knockout of that protein. They have horribly severe OI. And it increased their bone mass in these mice almost back to normal, this antibody. However, it didn't alter the material property of the bone, which is disappointing. What we can say is that it remains a possibility as a drug for the future. Something that we could look at as a complete alternative to the traditional sorts of therapies that we've used. Okay. Did anybody have any questions about that stuff?
When you take this drug, when you're pregnant, can you take it?
Okay, so when you are pregnant, you shouldn't take any medicines at all if you can possibly avoid it. Okay, and that doesn't matter which medicine we're talking about. As far as we know, having said that, if you were to become pregnant and you didn't know for some time and you were taking the medicine, that has happened a few times, and the cases that have been written up suggest that the babies have been fine. So it would be okay, but ideally you should not take the medicine while you're pregnant. Okay. Who's got an FD rod in? Anybody? Do you know what an FD rod is? Yeah? Oh? Your son has one. Okay. So these are FD rods, are Fassier Duval rods. So it's Dr. Fassier, who's the chief of staff of the orthopaedic group in the Shriners Hospital in Montreal, who invented these. And he did it because he got fed up with the Sheffield rods, which of course are definitely the best, because they kept not doing what they were supposed to be doing. So he invented a new sort of rod. They are incredibly expensive. But they do a good job, and particularly they're a great rod for the tibia, because you don't have to open the ankle joint, you can do everything from the knee, and it's much easier for the surgeon to do that, and recovery times, as I understand it, are a lot quicker. But like all rods, they break or they bend and they need fixing. And over a sort of a 5 to 10 year period, nearly half of them had to be fixed, about half of which were because of somebody falling over and having a fracture. They did have some problems with getting them to stick where they should be, which was the original reason for inventing them, because ours, Sheffield rods didn't quite stick where they should be either. Good news is if you need an MRI scan, FD rods don't move, and neither do any of the others actually. Don't, under any circumstances, if you have any metalwork in, get into a 3 Tesla MRI scanner. Okay? 3T MRI, your rods will heat up, and it is excruciatingly painful. People say who've got a lot of fillings, if they go anywhere near a 3T MRI scanner, they can feel things happening in their teeth. So my strong advice to you would be avoid strong MRI scanners. But 1.5 Tesla, which is the typical bog standard MRI scanner, should be fine. They've used titanium rods in the spine for some time now. In terms of rodding in the arm, it's difficult. You can't get rods to stay in the humerus, the upper part of your arm, very easily. And the surgeons, both here and in the United States and Canada, have all struggled with that. One thing that did come out from what he was talking about was that if you've got a bend in your forearm of more than 20%, it will interfere with your ability to turn your hand over. Okay, so those sorts of deformities are probably worth asking to get fixed, because they will lead to a lack of ability to turn your hand over, which can be important at times. Okay? Any questions? Remember, I'm not a surgeon and I can't answer these things, but hopefully somebody else will later.
Talking about deformities in the arm, I've got quite a bad deformity in the left arm, and I can't rotate my wrist. But I was actually told that it was available for enough. They didn't want to interfere with my arm in case it damaged my hand. So I just wondered if there had been progress since then, because I was very nervous about it.
Sure. I think it very much depends on the level of mobility and range of movement that you have. And that's, again, an individual discussion for you to have with your doctors and your surgeons. Because if the function that you've got is as much as you need, then you don't need the operation, basically. And to do it would just be unnecessary and potentially harmful. But if you get to a point where it is limiting you significantly, then it's probably worth revisiting. Okay.
When a child has a trauma and they need rodding, what rod or what pin or what advice do you give for parents who turn up at the A&E department, end up on a ward, and the child's going to surgery? What should we say we want?
Here's my friend, Mr. Fernandez. He'll sort you out.
But when you're stuck in a hospital, perhaps maybe in Ireland or in Manchester, what rod are we recommending for femurs specifically? And tips maybe? Femurs are the main one.
I think tibias, the fascia dural rod has shown its worth. For the femur, you've got a range of choices, and it depends very much on the experience of the surgeon, the size of the child, how big the hole down the middle of the bone is. There's a lot of different factors you take into consideration. If you've got somebody who's nearly finished growing, you wouldn't necessarily put a telescopic rod in, okay? Because even if they've only got another centimetre or so to grow, it's not worth it. They are more likely to break than a fixed, static rod. And some of the static rods as well are quite hefty, and they also have the facility to put screws through them, some of which can go up through the femoral neck and help to stabilise the angle of the femoral neck in the thigh bone as well. So there are a whole series of different considerations for those sorts of situations, and it is very much, again, an individual discussion with an informed operator. And if you're not happy with the advice you're getting, my advice would be ask to see somebody else. Or go somewhere else. Because there are places where these things are done on a regular basis.
Yeah, I've got a titanium pin in my left humerus, which Mike Bell did about 12 or 13 years ago now.
Yep.
But it's kind of on the move, and I know it's on the move. So now that Mike Bell's retired, I'm living in Newcastle now. So I've actually gone to see Mr. Hinman. So he's taken a look, had a look at the x-rays, and has agreed that, things are on the move. He's a bit reluctant to go in there and start fiddling around, I think, but he said when the time's there and it actually breaks, he will do it. But I'm just wondering if there's opportunity for Newcastle and Sheffield to talk to each other, because I get the feeling there's more OI expertise from Sheffield. Newcastle are building, we're getting there, but...
I think with all of these sorts of situations, the surgeons generally are very happy to talk to each other. Some more so than others, but generally they are quite happy to talk to each other and share their expertise. So for instance, spine cases aren't done in Birmingham, they come up to us in Sheffield because the spine surgeons there don't feel comfortable with doing them, they don't feel they have enough experience. And yet Birmingham is a big centre. So it does depend, I think it also depends on those individual relationships, particularly if people have worked together before. But up in, it's Mr. Montgomery, have you come across him? Yeah, I think he's somebody up in your part of the world who has had quite a bit of experience with OI. So the other thing to do is just to say to your surgeon, have a chat with him and see what he says. Sorry? Mr. Montgomery? Ooh, I thought he was still around. I think he's still around. Mike Bell's retired now.
What age do you think is the best time to get fixations and things like that? Like what time do you sort of stop growing?
Okay, so girls generally stop growing by the time they're 14 and a half, 15. And boys, it can be any time up to 18, 19, 20. But fixation doesn't really depend on when you stop growing. So it's you get what you need when you need it, essentially. And it should be tailored to you as an individual. There aren't fixed times when you should do things, necessarily. There are times when it's technically difficult to do things, and areas that it's technically difficult to work in. So the upper arm is a technically difficult area, and surgeons may prefer to say, or may say to you, I'd rather wait until you need fixing and it breaks, or I'd rather wait until it's bigger, because I don't think I can do it with the size of bone that we've got to work with at the moment.
I've only had one operation, it didn't go so well, but I need to get the other side done, but I'm not sure when to get it done, whether to wait.
And the answer is that's a discussion that you need to have with the person who's going to do the operation, really, as to what suits you best.
It's more a comment than a question. To illustrate what Care for Brittle Bones is trying to add. So, Nick, you were actually at some point in time forwarding a proposal to us that came from Mr. François Fassier from Canada. They wanted to start a collaboration site, a virtual collaboration site on the internet for surgeons to discuss difficult operations that needed to take place, particularly also for countries that do not have that specialized medical care. So we're now looking at that and how to operationalize that, and hopefully by the end of the year that will be live, and then can really kind of picture that would be enormous, really tangible added value for very highly specialized operations, for specialized doctors like Mr. first year himself to consult and think with the surgeons in all kinds of places across the globe. Yeah, so just to highlight very specifically, it doesn't cost a lot of money, by the way, but that's the stuff we're trying to move with our people.
Thanks for reminding me about that, Dagmar. I should remember. So that opportunity, I think, is a really important one. There can be issues within an individual country about sort of personal rivalries between surgeons. Once you globalise things like this and you can start to go outside country borders, I think you get a much better perspective, and the opportunity for really improving care overall, I think, is increased. So it's a really good initiative.
My son Henry had both his feet rotted last year after quite a bad femur fracture, his first long bone fracture. And Mr. Fernandez said to us that obviously they're deciding now to rod earlier because of the bisphosphonate effects of the bone filling up, as it were. Is there anything to suggest that there's a specific sort of number of times that you'll then be able to have rods reinserted? If kids are having their rods put in earlier?
No.
Right.
There's no limit, basically. You can keep going and having your rods changed, as long as it's required, as long as you're doing it because you need to, rather than just sort of following the numbers, as it were, and saying, oh, 2 years are up, you need to change your rod. You won't do that.
So that is done purely on growth rate, is it then?
Yeah, and individual need, yeah.
There was talk that some surgeons aren't comfortable carrying out such special, surgery. What advice would you give to a parent or an adult who is not comfortable with their surgeon, in carrying out that surgery? And if, do they have the same choice really of to move on and have someone else do it? And another comment there was about surgeons talking to one another. But sometimes that information is not really back down to the patient, so you kind of are not aware of that communication that's happening above your head and whether it's even taking place?
I think those sorts of questions are really difficult for me to answer, Vincent, because it does come down to your relationship with your surgeon. If you're not happy with it, then I think your options are fairly limited. You can ask to go elsewhere, but it can be tricky because if you're in Northern Ireland and the services provided there, the government may not be willing to pay for it to be done elsewhere, and that is a real problem then. I'm not sure how to solve that one. Hopefully, though, if this kind of global exchange forum for surgical or for specialist surgeons takes off, and people use it effectively, people's practice will change.